So thank you very much indeed for the opportunity to address this title. Is perioperative acute kidney injury preventable? I'm Monty Mythen. I'm an emeritus professor of anaesthesia and critical care from University College London. I'm also privileged to be an adjunct professor at Duke University Medical Center. I have some potential conflicts of interest as listed here. I think that most of them are not directly related to the talk, and most of them are academic conflicts, including my relationship with TopMed Talk, which is a free open source medical podcast channel, and Evidence-Based Perioperative Medicine, which I'm a founding director and is celebrating its 25th year. I'm also a co-director, founding director of the Perioperative Quality Initiative, and I'm going to be pivoting off this particular publication in Nature Reviews Nephrology, published in September of last year, done in partnership with the ADQI, the Acute Disease Quality Initiative. And here the group has addressed postoperative acute kidney injury in adult non-cardiac surgery. It's a joint consensus report between the two organizations. I'm going to start by highlighting box 7, consensus statement 7A, that talks to the outcomes of postoperative acute kidney injury and acute kidney disease, i.e. the bump in creatinine followed by a lingering elevation of creatinine. I'll show you that in a diagram in a moment. This consensus statement says that the incidence of kidney and non-kidney adverse events is increased following postoperative acute kidney injury or postoperative acute kidney disease, and both of them place patients at risk of going on to develop new or worsening chronic kidney disease that's associated with long-term mortality. Showing that diagrammatically here, what we see along the bottom of the slide is from contemplation of surgery through anesthesia and the surgery procedure, and the number of different colored lines that represents elevations in creatinine. So in the postoperative AKI period, the blue line represents a small bump in creatinine, the red one, a bump in creatinine that's consistent with the diagnosis of acute kidney injury. So more than 1.5 times baseline. But in that example, it comes back down within 7 days. There are then other curves which the acute kidney disease, either lingering beyond 7 days and up to 90 days occurs. And all of those have the potential to transition into chronic kidney disease. That's now extremely well described and accepted based on very large data sets from many countries around the world, including robust US data. So any patient who has a creatinine bump more than 1.5 times baseline is at risk. There is no such thing as the benign creatinine bump that I was taught as a young doctor or medical student. Now, if that goes on to become full kidney disease that requires dialysis, even in the short term, we know that's rare, thankfully, but it's also a very bad outcome. So if we look at this example here, which is recently published, it's a single center study of 157 patients who went on to require postoperative dialysis. Whether it's abdominal surgery, cardiac trauma, vascular, or other, the mortality rate is 50% or greater. Now, most patients are emergency patients, which we would expect, but 28% of them had elective surgery. So it's not that this does not happen acutely, it does happen, thankfully, rarely. But the bump in acute kidney injury that we see at phase 1, the elevation of creatinine not requiring dialysis, is much, much more common. Here's another example, relatively recently published. It's looking at the acute kidney injury and its progression to chronic kidney disease over time. It's 5,500 patients, and within the paper, it demonstrates the fact that acute kidney injury is quite common, at phase 1 acute kidney injury, and that any form of acute kidney injury is associated with faster disease progression. And actually, the phase 1, that creatinine going up by 1.5 times baseline, is the greatest risk that was seen in this study. So that highlights the importance of perioperative kidney protective strategies. These terms have now crept into our lexicon. We're seeing them reported around the world, and recently quite often in the United States of America. Hospital-acquired acute kidney injury, hospital-acquired acute kidney disease, hospital-acquired acute kidney failure. That implies the fact that most postoperative acute kidney injury is iatrogenic. And if it is iatrogenic, i.e. it occurred in hospital and was possibly caused in hospital, we then have to ask ourselves the question, is most postoperative AKI preventable? Back to our guidelines from POKI-ADQI, consensus statement 4A. from box 4, prevention of postoperative acute kidney injury, intraoperative strategies. 1, 2, 3, 4, 5 recommendations, of which I'm going to deal with the top 3. I'm not going to deal with the bottom 2, but they're there for you to read in the paper, which is free and open source. So consensus 4A says we recommend not using restrictive or zero balance perioperative fluid regimens. We know that perioperative fluid administration is pretty chaotic everywhere we look at it. This is one example published in the Annals of Surgery by myself and Julie Thacker, a surgeon from Duke and colleagues, where we got access to the Premier database and over 500,000 cases, colorectal cases and primary joint replacements, so hips and knees. Multiple centers in the USA. And we've looked at length of stay, total cost, and post-op ileus. And for everything that we looked at, when we compared the middle 50% of patients to the outliers on the wet or the dry side, liberal or restrictive, we saw a U-shaped curve. I'll explain that in a little bit more detail. This diagram is well established. It's given credit to Mark Bellamy. He wrote an editorial in the British Journal of Anesthesia called Wet, Dry, or Something Else. It represents the amount of fluid given during surgery, normovolemia in the center, hypervolemia, i.e. excessive to the right as you look at it, hypovolemia to the left as you look at it. And it suggests the fact that at either end of the spectrum, there's increased risk. Too little, you underperfuse organs. Too much, you end up with damaging edema. And in the middle is the sweet spot, and the size of that sweet spot is dependent on the procedure, comorbidities, preoperative hydration, bowel preparation, the type of anesthetic, etc. Now, in the example I showed you from the Premier database, published by myself and Julie Thacker in the Annals of Surgery, what we've done here is we've looked at over 500,000 primary hip and knee replacements. This is elective surgery, and over 80,000 patients having colon surgery. And we've looked at the amount of fluid the patients have received on the day of surgery. Now, I know we're thinking, surely you have to adjust for time and bleeding and all those good things, and that's all explained in the paper. But the big picture is that 50% of the patients, quartiles 2 and 3 in the middle, received about 3 litres of fluid, which seems sensible to me. We're going to call that the sweet spot. We're now going to compare the patients in the top 25% who received for their colon surgery more than 5 litres of fluid, and for their hips and knees more than 4 litres of fluid, which possibly seems quite a lot, but maybe they were longer, maybe they were bleeding. We'll call that liberal. At the other end of the spectrum, we have the patients in the bottom 25% who received less than 2 litres, 1.7 or less for their colon surgery, which really doesn't seem like very much to me, or less than 1.25 litres for their joint replacement, which also doesn't seem like very much to me. We're going to call that the restrictive group. So 50% in the middle, 25% at either end. Now, whatever we looked at, this U-shaped relationship could be found. So these are the colon surgeries, the 50% in the middle compared to the wet or liberal 25%, so sweet spot compared to liberal, and compared to restrictive. At either end of the spectrum, outcomes were worse in terms of cost or ileus, etc. This is ileus, and for those of you who think it's good to keep patients dry during colorectal surgery to avoid ileus, running patients dry, restricting them, causes ileus because the gut doesn't like being underperfused. Sweet spot compared to liberal, compared to restrictive. So fluid restriction. Well, this term has crept in associated with ERAS for the last 15 or 20 years. Has no physiological basis to it. There's no benefit of being fluid restricted. There's no advantage to being dehydrated or hypovolemic. But it became popular as an alternative to the sort of Michelin man type of patients that we used to see at the end of the last century, in the late 1990s. So when fluid restriction became popular, it was really saying avoid fluid excess. But then the pendulum swung too far, and we were starting to hear from people who enjoyed practicing fluid restriction saying, well, my patients look great in recovery. They breathe well. They go home quickly. All true. Let's look at some data from a US center published in 2017. And what we're looking here, the Annals of Surgery, is 92,000+ patients from a single well-respected North American center. They've divided the fluid given on the day of surgery into quintiles. So 20% of patients in each group, going from Q1 to Q5, which is the driest to the wettest, the restricted to the liberal. And you can see there appears to be this U-shaped curve. I'll talk you through it in a little bit more detail. So if you concentrate first on the 30-day mortality, it does appear that Q5 has statistically significantly more mortality compared to Q2. Q1 looks like it might be going up, but not statistically significantly. Well, here we've got that compounder possibly of longer surgeries, more bleeding, more fluid. It doesn't explain the little bump in the restricted though. If you look at post-operative pulmonary respiratory complications, and here's where the problem comes from, there's clearly a hockey stick here. So the uplift in respiratory complications is in the Q4, Q5, so the 40% of patients receiving more fluid. Again, possibly compounded by duration, blood loss, etc. If you look at length of stay, it's quite dramatically more increased at the wetter end of the spectrum. But now look at cost. Cost is actually greatest in the driest group. So the highest cost is in the driest group, the restricted group. It's also higher than Q2 and Q3 in the more liberal group, but it's highest in the driest group. And why is that? Because of silent acute kidney injury, seen both in the wettest patients, probably for the same reason as the mortality and respiratory complications, but also there very worryingly in the driest group. So fluid restriction has now been examined in the world's largest prospective randomized controlled trial. That out of Australia by Paul Miles and colleagues, they randomized around 3,000 patients to either have a zero balance approach during major intra-abdominal surgery, intracavity surgery, mainly colorectal surgery. And they divided them into patients who were run close to zero balance or those who are moderately liberal. And moderately liberal is only about +1 to +2 liters positive at the end of the case. So roughly a 3-hour procedure, patients ended up receiving about 3 liters of fluid, remarkably similar to the median in that large North American data set. And they had better outcomes. So they did the study with the prejudice that zero balance would produce a better outcome. But they found that the restrictive fluid regimen was not associated with any improvement in outcome, but it was associated with statistically significantly more kidney injury, including dialysis-dependent acute kidney injury. So very disturbing. So at the end of that, I think we can say with great confidence and evidence-based approach that fluid restriction is a bad idea. It doesn't help. It's bad for patients. Please don't do it. So that's our first big takeaway. It's okay to go back to giving 10 mils per kilo around the time of induction of anesthesia. I was brought up with that being normal. It's now, as far as we can tell, the right thing to do. Be a little bit generous with the fluid, but not too much. Keep it under that +1 to +2. But zero balance is hypovolemic and is associated with worse outcomes. Consensus statement 4B. We recommend the use of goal-directed hemodynamic therapy in high-risk patients to optimize volume status, blood pressure, and cardiac output. Strong recommendation, grade B evidence. So here are the POCI guidelines, very familiar. As we look at them, we're looking at the risk stratification of patients. Along the bottom is procedural risk factors, so greater duration, more bleeding. On the at the side are patient factors, so higher ASA score. So top right-hand corner of the diagram, the pink square as you look at it, are the patients who are high-risk surgery, high-risk patient, probably going to a high-care environment and therefore receiving cardiac output monitoring. The bottom left-hand corner are the ASA 1 to 2 patients having shorter, lower-risk surgeries. That's blood pressure cuff, minimal monitoring standard. That's the majority of patients. But the gray zone in between are your high-risk patient having a low-risk procedure or your low-risk patient having a high-risk procedure, who on balance probably should have more monitoring than just a blood pressure measurement. On the right-hand side, as you look at this slide, the other green box is goal-directed therapy in the context of enhanced recovery. So minimizing the NPO period, allowing clears up to close to the last minute and encouraging patients to pre-hydrate with a carbohydrate-containing drink. Avoiding bowel prep unless it's completely necessary, and if it is necessary, then it should be an isoosmotic bowel prep. Then stratifying your patients according to this low, intermediate, and high risk. Deploying your cardiac output monitoring to the intermediate and high risk patients, of which there are now very many minimally invasive alternatives to the invasive options that we had in the last century. And then use those according to the framework in the center that I will come to in a moment. And then get your IV down as quickly as possible post-operatively, because the patient is now drinking and therefore sorting out their own fluid balance. And then at the bottom, it shows drink, eat, analgesia, move, sleep, dream or dreams, and get your patients home as quickly as possible. In the middle is the hemodynamic framework. It's what we do every day of the week. Is there a problem? What do I think is causing the problem? And now in the high-risk patients using my cardiac output monitor, what's the stroke volume? How does the stroke volume respond to a preload adjustment, a table tip, or a fluid bolus? And then most importantly, use our brains. And then turn around and say, do I think the problem here is preload? So I give volume. Do I think it's afterload? So I give a squeeze of my phenylephrine or whatever I have. Or do I have evidence to suggest the fact that they need more contractility? So am I switching to ephedrine, for example? So we treat the problem, and please, we don't just treat the blood pressure. Although blood pressure is important, consensus statement 4C says that we recommend you must keep the MAP above 65. That's the current evidence-based recommendation. It comes from predominantly observational studies, large observational studies, and many of them multi-center US observations, suggesting the fact that harm can occur above 65, but 65 is probably the most reasonable threshold to not let our patients go below. Even if you adjust for baseline blood pressure, it's still the 65 is the sort of generally agreed hard deck. And it comes from these types of observations from the Cleveland Clinic, for example, where here we're looking at the estimated probability of myocardial injury or the estimated probability of acute kidney injury. And we see for duration starting at 1 minute, 3 minutes, 5 minutes, 10 minutes, that the threshold of about 65 millimeters of mercury shows an increased risk and association with those poor outcomes. Hence, that is the threshold we aim for. Now, the fear with having just a blood pressure threshold is the unintended consequence that we worry about, that people will start a vasopressor infusion, not address volume and flow, but just address pressure, which we all know is a disaster. Treating patients who are mildly hypovolemic and or dehydrated with pre-existing nephrotoxins on board during surgery with just a vasopressor is basically switching off some of their end organs. It switches their gut off very early, shortly followed by their kidneys. The heart, lung, brain looks fine, but you're causing potential damage. And we're now starting to see reports. This one published very recently as a 2022 publication in the journal Renal Failure, showing that high vasopressor use is associated with postoperative acute kidney injury in elderly patients, independent of the hypotension. We saw this in the United Kingdom with our enhanced recovery rollout. We're hearing anecdotal reports of AKI rates going up in the USA, and now we're seeing publications supporting that. So please don't just squeeze in isolation. What we're saying is that we should take a holistic, goal-directed approach. This is a multi-center trial published on relatively low-risk patients, so intermediate-risk patients. It's a multi-center randomized controlled trial. It's a 420-patient RCT, and it used this approach where you address volume, preload, then afterload, and contractility. So stroke volume, cardiac index, and MAP are measured at baseline. A fluid bolus is given to optimize stroke volume, so now you've addressed volume. You then look to mean arterial pressure, and if the MAP is greater than 65 and the index is greater than 2.5, you do nothing but continue to monitor to keep an optimal stroke volume. If the MAP is below 65, but the index is greater than 2.5, you give a vasopressor. If the MAP is less than 65 and the index is less than 2.5, you start an inotrope. So it's either do nothing, squeeze of phenylephrine, or a squeeze of ephedrine, or whatever you choose as your preferred therapeutic agent. If it continues, then we continue to address stroke volume, but now we start an infusion, which is not needed in most patients if we address volume first. What happened in this study? Well, consistent with the meta-analyses and the 100+ goal-directed studies to date, the majority demonstrate that there is a reduction in overall morbidity, 16.6% down to 8.6%. There's a statistically significant reduction in acute kidney injury, acute lung injury, cardiopulmonary edema, pneumonia, and surgical site infection. These are very highly consistent results. And the acute kidney injury goes down from 8.5% to less than 1.5%. So not completely avoidable, but almost completely avoidable. So let's put those two studies together in close to conclusion. So the relief study on the left-hand side as you look at it, which was the 3,000 patients, restrictive versus moderately liberal. And on the right-hand side is the goal-directed Fedora trial. So we put them together on this slide. There are the references there at the bottom. The blue boxes are the relief trial. So the relief trial, 3,000 patients, had a baseline, a control group acute kidney injury rate of 8.5%. For the liberal group, it's down to 5%. And that is just by being more liberal with the fluid. So giving that liter induction of anesthesia and then being a little bit more generous during the case, old school, such that they're about +1 to +2 positive at the end of the case. That is the new sweet spot. If you deliver a patient in the PACU 0 balance, they're actually hypovolemic, they're under-resuscitated. Now, the next one is the red boxes, which is the goal-directed approach. So you have a control, remarkably similar, 8.5% renal failure rate. When you use a goal-directed approach, it drops to below 1.5%. Now, what that says to me is that hospital-acquired kidney injury is not completely preventable, but it's almost completely preventable. So it is iatrogenic, and therefore using the terms hospital-acquired kidney injury, disease, and failure are entirely appropriate. We don't have time in this talk, but you may hear about it from some other speakers in this meeting. Dan Engelman, for example, about what we're seeing now with the use of biomarkers to reduce acute kidney injury, in this example following cardiac surgery. So I encourage you to look into this further. These biomarkers that tell us the kidney is experiencing stress, not that it's failed or been damaged yet, but it's hurting. There's cell cycle arrest markers, of which there's a range of them available now, that when you sample them, you can say, this kidney is at risk, and we have a window of opportunity here to save it. And the results from that are looking very encouraging. Reports, for example, again, after cardiac surgery, of almost completely eliminating acute kidney injury, again suggesting that it is iatrogenic. Final statement here, probably the most challenging from the POCI-ADKI group. The prevention of new or worsening CKD following an episode of postoperative acute kidney injury or postoperative acute kidney disease is a public health priority. We recommend that all patients undergo at least one kidney health assessment once the phase of AKI or AKD is complete. This approach will require optimal communication and AKI education between healthcare professionals and the patient or caregiver. Very challenging, but actually, why would we not do this? It's basically saying, if your patient under your care has had a creatinine bump greater than 1.5 times baseline, even if it recovers before they're discharged from hospital, you now have a duty of candor to inform them that they have had acute kidney injury, hospital-acquired acute kidney injury. Must then try and ensure that they have, in the weeks and months to follow, a follow-up where their creatinine is checked and their urine is dipsticked. And if the creatinine is still elevated and or they have protein in their urine, they should be referred to a nephrologist because their risk of ending up on dialysis and dying is now greatly increased. And it's hospital-acquired. So that is extremely challenging to all of us. Some places are now getting systems in place to close out on that. But we all really sort of have to ask ourselves, well, yes, of course we should do that. Or we would do it if they had an anaphylaxis, for example. Why would we not do it if we hurt their kidneys in a way that was unavoidable? Having done everything possible to prevent it, if it ends up in this individual being non-preventable, we absolutely have a duty of candor to let them know. I don't know how that's going to play out, but there's the challenge to us. So in conclusion, postoperative acute kidney injury is a public health priority. It's recognized by governments around the world. It's recognized by the US government as a priority area for healthcare improvement. Hospital-acquired iatrogenic acute kidney injury is almost completely preventable. In this talk, we haven't gone into the avoid nephrotoxins. I hope that is self-evident to folks. Whether it's non-steroidals or other nephrotoxins, we must be mindful of the dose we administer those. Interestingly, most of them are safe in the perioperative setting if we avoid hypovolemia and hypotension. So we should use a moderately liberal fluid balance and avoid a MAP less than 65. So if we're still not going to use cardiac output monitors, we should at least make sure that we're moderately liberal and keep the blood pressure above 65. We can all do that. Hopefully we do have cardiac output monitors, and for our intermediate and high-risk patients, we can use a goal-directed approach. We can pursue the goals of fill, flow, pressure, and produce the best possible outcomes. Biomarkers offer further potential to reduce hospital-acquired AKI. Our patients who, in the post-operative period, have had a secondary little deterioration, we have a chance to scoop those up. The most challenging thing is if patients experience AKI, we need to tell them, and we need to arrange follow-up. And we can anticipate being put under increasing pressure to do that. So my instinct there would be to try and avoid AKI and try and avoid the need to tell our patients that and to arrange follow-up. Thank you very much for listening. Please enjoy the rest of the meeting.